Thank you, Dr. Cohen, Dr. Lichtenstein, and I also want to thank the organizers, Dr. McDermott and Hanauer, for asking me to speak on this topic. It's really a great subject, and here we go. The differential diagnosis of colitis is very broad, and we have to consider this isn't absolute, but in many ways, ulcerative colitis is a diagnosis of exclusion, and we have to be sure we've done the appropriate cultures, stool cultures, to rule out infectious colitis. And with C. diff, I think that we have to be sure that we're doing not only a C. diff toxin, but a C. diff PCR to be absolutely sure there is no C. diff present responsible for flare or diarrhea. We have to rule out Shigella, Salmonella. We have to be concerned about CMV colitis, especially in the severe hospitalized UC patient, and biopsy is required for that clarification. And then for the differentiation of other forms of colitis, UC, Crohn's colitis, and these others, biopsy is essential. And I think in most circumstances, especially for a baseline evaluation, one wants to do segmental biopsy of the rectum, sigmoid, descending colon, and transverse, ascending colon, cecum, and ileum, if possible. In ulcerative colitis, there is rectal involvement that extends proximally. It is a mucosal disease, and so what you see is what you get. It's typically continuous, involves only the colon, though backwash ileitis may be seen. Colonoscopic evaluation of UC is the gold standard. It allows for visualization and histological assessment. One can assess disease activity, classify endoscopic disease grade, and in a more research or research-esque nature, endoscopic subscores. Also perform surveillance, and importantly, assess disease extent. And again, to properly assess disease extent, and this is true of UC and Crohn's disease, biopsy is essential, because many times, even with our excellent endoscopes that we have, biopsy is needed to truly characterize the extent of disease. Ulcerative colitis activity scoring systems do accurately assess mucosal disease, although again, as Gary suggested earlier, there is some variation in interpretation and difficulty with all of these indices. They do not necessarily correlate with symptoms. They lack assessment or impact of extraintestinal manifestations, but they are used and are essential in clinical trials. And these include the Mayo score, the UCEIS, which Gary described earlier, and these can be applied to clinical practice. They may not be widely done so, but in the future, I think the potential certainly makes good sense. Colonoscopic features of ulcerative colitis, the visualization may be normal, but again, biopsy may show that there is active inflammation, and so that should be done when the concern is there. But if there is active disease, one often sees decreased or blurring of the vascular pattern, erythema, submucosal hemorrhage, and again, these are features that are increasingly severe or increase in severity. Edema, friability, exudate, it used to be called mucopus 40, 50 years ago, erosion, ulcer, bleeding, pseudopolyp, stricture. Extent of ulcerative colitis can be categorized into 5 different types, and that may be proctitis limited to the rectum, proctosigmoiditis, left-sided colitis, extensive colitis, which is a relatively new term, perhaps over the last decade, that includes disease to the hepatic flexure, and then disease beyond the hepatic flexure is termed pancolitis. There are many confounding features in ulcerative colitis, and one of those is being certain that this is UC or Crohn's disease, and certainly with rectal therapy and the use of suppositories, foams, or enemas, there can be rectal sparing or some left-sided sparing that can make ulcerative colitis look like Crohn's disease. The use of mesalamine compounds that cause segmental treatment and perhaps even immunomodulators and biologics can also lead to skip areas that may obscure the continuous nature of ulcerative colitis. The colonoscopic grading of UC includes remission, mild disease, moderate disease, and severe disease. And this is also nicely, simply paralleled in the Mayo endoscopic subscore that we'll talk about in this next slide. These are images that hopefully you can fairly well see from your seats that show the 4 different scores, the 4 different Mayo subscores, and the correlating images that go along with it. And on the left, we have normal or inactive disease. Then a Mayo 1 is mild disease, which is characterized by either erythema, decreased vascular pattern, or mild friability. There's moderate disease, where there's marked erythema, absent vascular pattern, friability, and erosions, and that's a Mayo 2. And then over on the right, more severe disease, a Mayo score of 3 with spontaneous bleeding and or ulceration. There are some historic scores that exist, and one of these is the Barron score, and I'm not going to go into any great detail here, but this was based largely on the amount of bleeding that was associated with the sigmoidoscopy or colonoscopy exam, with very little reference to ulceration. So again, this was looking at bleeding as a manifestation of UC and severity. Subsequently, the Barron score was modified, thereby termed the modified Barron score, where the scores of 3, which again is more severe, and a score of 4, which is most severe, included micro-ulceration and gross ulceration on top of the lesser grades seen below. The UCEIS, which Gary referred to earlier, is, again, the most comprehensive score that exists. And again, I don't expect this to be a lesson in how to score by the UCEIS, but I simply do mention it as a reference or framework by which we should be viewing patients with UC and interpreting the scores. And the descriptors, as you see on the left, and one's supposed to score the most severe lesions, you judge things on the basis of vascular pattern, bleeding, and then erosions and ulcers. And these images, these slides will describe things fairly well, and I want to thank Brian Fagan and Robarts for sharing some of these definitions and some of these examples with us today. So one is looking at the vascular pattern, and on the top, it's a normal vascular pattern, and this is characterized by arborization of capillaries, clearly defined, or with blurring or patchy loss of capillary margins. Then in the middle, one sees less distinctness, and that's patchy obliteration, and on the bottom, complete obliteration of the vascular pattern. So again, vascular pattern, one descriptor, one component of this UCEIS. Bleeding, again, these are features, again, that we should be attentive to when we do our exams, and we should be including in our descriptions. So talk about the vascular pattern. Talk about whether there's any blood present or not. And so there may be none, as on the top image. There may be some slight blood present, or there might be submucosal blood present, and that should be described. So that wouldn't be free blood, or there might be a tiny bit of free blood called mucosal. bleeding. There may be luminal bleeding, a very small amount, a luminal mild, or on the bottom, and I'm going to show you a video of the lower case shortly, that is luminal moderate or severe bleeding where there's frank bleeding ongoing during the procedure. And then the third descriptor, again, which we should be integrating into our reporting, whether or not we use the UCEIS or not, are erosions and ulcers. And there may be none, or there may be, as on the top of this slide, there may be a patch of tissue that is discontinuous with the surrounding tissue, and that is either an erosion or an ulcer. It's an erosion if it's tiny, less than 5 millimeters in diameter, and again, that is a defect in the mucosa. It might be white, might be yellow, but has a flat edge, or in the middle, it may be a superficial ulcer, typically 5 millimeters or larger. It's a defect that is discrete, maybe fibrin covered, clearly larger, but no real depth to it. And then in the lower image, a deep ulcer, which is a deeper, seriously excavated defect in the mucosa with a raised edge. So these are the features which we should be attentive to and describing when we do our sigmoidoscopy or colonoscopy exams. Additional examples of endoscopic descriptors include decreased vascular pattern seen in the middle, absent vascular pattern on the right, erosions, ulcer, and more diffuse ulceration. And regarding bleeding, there may be friability, which occurs as a result of instrumentation, or there may be spontaneous bleeding seen here. Now I'm going to share with you a series of videos which will demonstrate some of the descriptors, some of the features that I've shared with you already. So let's go back on that one, and that was a quickie, and do that once again. I unfortunately don't have control of that here. Can you go back one more time and don't advance immediately? I want to just show you that there's normal arborization of the mucosa here and the absence of any tissue defects. So again, this is normal. But this patient came in with diarrhea, and I did a colonoscopy, segmental biopsy, and the biopsies came back collagenous colitis. So again, a normal colonoscopy is not enough. When a patient presents with symptoms, especially diarrhea, biopsy is essential to characterize the microscopic colitis, and then occasionally you'll identify granulomas, making it Crohn's, and certainly other features you're already familiar with. Go ahead and start. So this is a patient who a few years ago had ulcers and erosions in the left side of the colon, and can you go back to that image and just leave it there? And now, normal vascular pattern, no defects, good arborization of the blood vessels. Slide, next one, please. So, okay, let's start. And this is an example of mild inflammation, equivalent to a Mayo 1, loss of vascular pattern in the mucosa. There's actually some moderate inflammation in this area here. Biopsy confirmed moderate inflammation in this patient in conjunction with many, many healed pseudopolyps. And this patient did have active symptoms with diarrhea, was markedly improved, but not in remission on biologic therapy. Slide, please. And this is an example of Mayo 2 or moderate colonoscopic disease. Again, a very granular, roughened pattern seen here. Erosions, these white defects are flat but do not wash off with irrigation. Again, some slight hemorrhage present, and again, this reflects moderate disease in the colon. And then this example is a little more advanced and shows moderate ulceration, patchy ulceration. Again, another patient on biologic therapy, improved, but not in remission, certainly not in clinical or colonoscopic remission. There's some partial healing there, but continued active disease. Slide, please. Okay. And then this example reflects deep ulceration. And when one sees deep ulceration associated with ulcerative colitis, it's certainly time to ratchet up therapy, either increase your current regimen, and in this case, this patient was already on a biologic, and it was time to switch to another agent because of ongoing symptoms and these colonoscopy findings. Okay, this is a patient who presented with rectal bleeding, and this was the initiation of a colonoscopy, and there was just frank blood and hemorrhage from the mucosa here in the wall of the rectosigmoid mucosa. So frank bleeding, again, equivalent to a Mayo 3, diffusely abnormal tissue that required immediate aggressive therapy. And now this next series is a series of 3 cases where I'm going to, or at least 3 images. This is something we saw before, erosive change, essentially a Mayo 2, moderate disease. Patient had 6 to 8 stools a day. Half of them were bloody. And so she was started on biologic therapy at this point, at week 0. And this is an exam that was done 8 weeks later, and there were only focal erosions that remained. Marked improvement in the mucosa, probably 80–90%. Some restoration of the vascular pattern seen down here. Then at 6 months, if we can have that video, please. There's complete normalization with, although there's some prep issues here, normalization of the vascular pattern and absolutely no tissue defects. Pseudopolyps arise in certainly in ulcerative colitis more than you see, and this is an example of pseudopolyps that we can bump into in this patient. They were present biopsies consistent with pseudopolyps, and when there are only a few like this, it's easy to biopsy and sample them. There's also some surrounding erythema present on this exam. Less erythema in this patient on biologic therapy, very little. Go ahead and start the video, please. And basically, pretty bland looking mucosa, no erosions, but again, no vascular pattern, total loss of the vascular pattern. Lots of pseudopolyps, making proper surveillance challenging, if not really impossible in this case. And here's a patient who came in for a surveillance exam, and 65-year-old male on 6-MP therapy, and basically he'd been symptom-free for 10 years. His exams had all been normal. We have normal vascular pattern here, no erosions, good arborization of the vessels until we get up to this point, and there's some debris. You wonder why the prep isn't so good here, and we're getting into some abnormalities that are a little hard to define without a little more irrigation and suctioning, and you suspect maybe there's a stricture there in that view. And just briefly advance the scope again, and I came up with a stricture that couldn't be advanced beyond. And this patient had biopsies. Biopsies were normal. CAT scan was normal, but the proper thing was to refer him to surgery. And this is an individual who came to the office with a severe flare of his UC. You see a little studding, little white nodules there on the left, but a lot of changes otherwise. That looks like a flare of UC. A C. diff had been sent, but it was a LabCorp test. Turned out to be a C. diff toxin that was negative. Repeated C. diff PCR, which was positive, treated with vancomycin, and he got completely better without any change in his UC therapy. And this is a patient with a known history of Crohn's disease for 6 years. She had ileal Crohn's disease and came to the office because of rectal bleeding. I did colonoscopy, and this showed inflammation, what looks like some ulceration, but with irrigation, this turned out to be an exudate that washed off. So it's important to kind of do proper irrigation if you can and characterize things. And basically there were micro-ulcerations here, but this is a case of UC-like Crohn's disease. And here are some more cases, refractory ulcerative colitis. This patient had bleeding and anemia, and this was certainly the source of things, again, successfully controlled with medical therapy. So in conclusion, a comprehensive evaluation of the entire colon is needed to make a definitive diagnosis of ulcerative colitis, and biopsy is critical. One needs to determine the severity and extent of the disease, and to do this, biopsy is critical as well. One needs to determine baseline disease activity to serve as a comparator for monitoring of UC and to determine appropriate treatment, and to perform colonoscopy at times of treatment changes when findings will have clinical significance, and of course for surveillance as well. Thank you very much.